Today we are going to discuss trauma. So trauma is one of the important topics for exams. There are so many questions in AIMS and PG Chandigarh from trauma. So let us discuss trauma in depth. Okay, we are going to discuss trauma in depth. I am going to discuss trauma chapter from Payne and Disorder edition and from Salisbury edition. And I am updating the points from the latest manual, ATLS manual, 10th edition. Okay, this is the latest edition. The problem is Bailey came before this edition. There are therefore some updates in Bailey, so which are corrected. So I will be updating those corrections also at the end of the chapter. So let us start discussion on trauma. Okay. So I usually discuss trauma more practically as if we are sitting in a trauma center. My topic will be going like sitting in a trauma center. Let us assume this is yourself, a trauma surgeon. You are a trauma surgeon sitting in a casualty. You are getting a phone call from a mass casualty place. There is a mass accident, big accident. Let us assume there is a bus upside down. Bus is upside down in a place very nearby, and there are multiple casualties. There are around 30 to 40 casualties. There is no specific number to define multiple mass casualty. Let us assume there is a multiple casualty in a place. You are getting a call from that spot. Sir, please come to this spot. There is a huge accident here. Please help us. Whether you are getting a call, but you are the only trauma surgeon in a trauma center in your district. Will you go to that spot? Will you go here? You will not go to the spot, but you will send your paramedical people. They will go to this spot using some tags. They will carry some tags with them, and they will carry some tags, and they will go and put those tags on the patients and ship them to the hospital. The tags color are red color tag, then orange color tag, then orange is actually yellow, red, yellow, green. It is like a signal. Red, yellow, green signal. So red is an immediate case to be monitored. The case to be monitored immediately, managed immediately. Within minutes, the patient needs management. Like immediate management needed for red tags. Red tag patients will need immediate management. They will put a red tag to this fellow, and they will ship this fellow to the trauma center like this. So and then they put the second patch to the yellow fellow, and they will ship that fellow to the trauma center second. Then they will finally put the green fellow, and they will ship him to the trauma center as a last fellow. He's the last person to be shipped. So this is phenomenon known as triage. Triage means to sort out. Remember that point. Triage means the word triage means sort out. So who will sort out? Not a doctor. It is done by paramedical people. They will go sit there in the accident spot and they will see the patients and they are trained to sort out the patients. So red fellows are emergency. Examples of red fellows are tension pneumothorax is an example of red. Tension pneumothorax. So please remember, tension pneumothorax is an example of red, which needs immediate management. Pericardial tamponade. Like these are the cases which are to be managed as early as possible. Within minutes, you have to manage the red patch. And then comes orange patch or yellow patch. So yellow, red, yellow, green are the three important patches used. This yellow should be managed in 2 hours. Should be managed in 2 hours. So this is not so emergency, but at the same time they deal with a serious cases like major bone fracture. Okay, major bone fracture. Like open pneumothorax. These all come under yellow. And green, please remember, these green guys are not at all emergency. You can treat them after 2 hours. They can wait. In fact, they can wait in the trauma center until the red and yellow are completed. So please remember, this is very important point. Green fellows, green patch people, what do you do? Green patch people can wait, and in fact, they themselves can come to the hospital. You will not ship them in the ambulance is lagging. The ambulance will be realized. You cannot go and ship them. Let them come slowly. For example, these are none but, for example, a tibia fracture, or this bone fracture, or small fractures, or small hematomas like that. Small injuries are coming under green. So green can wait. And in fact, we will ask them to come to hospital or go to the hospital nearby. They are going down directly. So that is green. So please don't forget red, yellow, green. Red immediately needs management. Sometimes the management will be started in the spot itself. If the surgeon or a trauma surgeon is there in the spot. Orange should be treated within 2 hours. Green should be treated in gradually after 2 hours. So these are the points I want you to remember in trauma. Okay, next point is here is we have to know about triage is done for whom will you do this triage? For a multiple casualty or a mass casualty. What is the difference between multiple casualty and mass casualty? What is the difference? What is the difference between multiple casualty and mass casualty? Multiple casualty is nothing but there are some injury patients coming to the hospital and your hospital is having enough source to manage all of them. For example, 5 patients are coming at the same time and you have 5 medical paramedical people to manage that. So you have adequate source to manage that casualty. That is known as multiple. And mass casualty is there are a group of people coming to the hospital. For example, 25 people are coming to the hospital and the source in your hospital is less. For example, you are only 5. This is known as multiple and mass. There is no specific numbers. I'm just giving examples, these are not the numbers. Okay, the multiple casualty means there is enough source to manage all the patients. Mass casualty means there is no enough source to manage all the patients. Please remember this point. Okay, multiple and mass casualty definitions. So this is a very important point. Triage, you should not forget triage of patients. Now let us assume you are admitting this fellow, Mr. Ramu, in a trauma center. He is Mr. Ramu, admitted in the trauma center, and you are a trauma surgeon. You are going to go in near this fellow and you are going to examine this patient. What will you do as a trauma patient first? That is known as primary survey. So as you go near this patient, what will you do in a primary survey? Primary survey, actual ATLS says A, B, C, D, E. So this is the primary survey of this fellow. So primary survey is airway, breathing, circulation, disability, and exposure. Airway, breathing, disability, and exposure are the A, B, C, D, E. This is known as primary survey of the patient. Airway, breathing, circulation, disability, exposure. I am going to discuss in this introductory chapter on all these issues. And Bailey says a small c in front of A, B, C, D, E. Small c, all others are capital. What does this small c stands for? Control of exsanguinating hemorrhage, not a small hemorrhage. It is an exsanguinating hemorrhage. For example, a person is having a continuity of internal that is bleeding, or femoral artery that is bleeding. Immediately you should go and back or compress that bleeding. Then only you go for airway. I am not asking you to control a hemorrhage coming from the nose or from an ear. I am asking you to control a bleeding, exsanguinating bleeding. So C for control exsanguinating hemorrhage is given in Bailey as ABCD in front of ABCD. That is a small c known as control exsanguinating hemorrhage. So now I am going to discuss one by one about these points. First, let us start our discussion on airway. A for airway. To each point I have taken from ATLS manual, the first priority in a trauma patient is given for airway. Okay, A for airway. How to say the patient's airway is good? You can easily find out the patient's airway is good. You just ask what is your name, and the patient is saying, sir, my name is Ram. If he is speaking like this, sir, my name is Ram. There is no difficulty in speaking. His voice is coming in full means his airway is patterned. The best way to assess the airway is to ask the patient talk. You ask the patient to talk, he will tell. His talking is good. His voice is coming good, then his airway is patterned. So no need to worry further. That is a very important point in airway. He is talking very fluently, that is airway is pattern. And in which condition you intubate? Intubation of a trauma patient. Intubation of a trauma patient is advised and the GCS score is less than or equal to 8. This is 100 times of MCQ. 100 times of MCQ. GCS less than or equal to 8, you should intubate. Okay, we are going to discuss all those things later. And in the first priority in airway, we must do certain maneuvers. So what are the maneuvers you do in stabilizing the patient? The maneuvers we do are number one. So in a trauma patient comes to hospital, they may be moving here and there, they may be shifted here and there. So immediately you put a hard cervical collar. I will show you the image of it. Apply a hard cervical collar. You can see most of the ambulance, they have this hard cervical collar. So they immediately put hard cervical collar and put the patient on a hard board, not on a bed. They will put on a hard board. They will put the patient on a hard board. They will put a hard cervical collar and then only they will mobilize the patient. And the moment they put this hard board and cervical collar, they will do the following maneuvers to prevent airway obstruction. What is the most common cause of airway obstruction in trauma? The most common cause of airway obstruction is the tongue falling backward. Please remember, the tongue, patient's own tongue falling back. How to prevent the tongue falling back? You can easily prevent tongue falling back by doing the following maneuvers. What are the maneuvers? Jaw thrust. Jaw thrust maneuver. Please remember, jaw thrust maneuver. You have to lift the jaw like this. Jaw thrust maneuver. Chin lift. Jaw thrust, chin lift. I will show you these pictures. Chin lift maneuver. Jaw thrust, chin lift maneuvers are done. What should not be done? Can you tell me? Jaw thrust, chin lift. What should not be done is extension of neck should not be done. Please remember this. Extension of neck should not be done. To make a good airway, to prevent tongue falling backward, I am not making extension of neck. Just like me. Jaw thrust, chin lift. That's all. Okay. Another one important thing we can do to maintain the airway is apply a Udal airway. Udal airway is an airway you would have seen in anesthesia department that will be like a going inside the posterior of the tongue and will prevent tongue falling backward. So Udal's airway. These are the maneuvers we maintain to prevent tongue falling backwards. So tongue falling backward, jaw thrust, chin lift, Udal airway are done for the patients. Okay. And now comes a very important thing that is going to be very important for exams is on intubation. Intubation. Putting a cuffed tube into the trachea is the best method to establish an airway. The best method to establish airway is to put a cuffed tube inside. So we can put two types of cuffed tubes. Commonly we do only orotracheal intubations. This is orotracheal intubation is what we commonly do. Okay, orotracheal intubation. Another intubation is nasotracheal intubation. Nasotracheal intubation. So these are the two methods of putting intubation. Another method of intubation is by putting a tracheostomy. So tracheostomy is the third method. Orotracheal intubation. What are the points you should know? Orotracheal intubation is most commonly done method of intubation and it is contraindicated in where in which place orotracheal intubation should not be done. Contraindicated in maxillofacial injuries more than one time. In a maxillofacial injury, you can do one time intubation. One time you can do intubation. In a maxillofacial injury, you can do one time intubation. More than one time, if there is a maxillofacial injury, we should not do orotracheal intubation. A maxillofacial injury, more than one time, orotracheal intubation is failed, means we should not do intubation. So up to one time, you can do orotracheal intubation. If it is failed for a second time, don't try for a second time. Okay, second time, you should go for a tracheostomy intubation. So please remember, nasotracheal intubation is contraindicated in the following. This is a very big question. Most of you will be knowing. Nasal intubation is contraindicated for base of skull fractures, especially anterior cranial fossa, cribriform plate fracture. Cribriform plate is fractured. Base of skull fracture. Patient having CS of rhinorrhea. CS of rhinorrhea is there for the patient. And fourth one, as usual, maxillofacial injuries. So maxillofacial injuries is the fourth one. So what are the contraindications of nasotracheal intubation? Are base of skull fracture, cribriform plate fracture, CS of rhinorrhea, maxillofacial injuries are places where we should not do this intubation. Okay, please don't forget these points. And in all these places where it is contraindicated, we should go for a tracheostomy. Please don't forget, we should go for a tracheostomy. Tracheostomy is mainly indicated for maxillofacial injuries. Okay, maxillofacial injuries, tracheostomy is mainly indicated. And in a maxillofacial injuries, emergency what you do? Emergency what you do? And electively what you do? In emergency, you all would have seen one needle being inserted in some movies. There is one movie came recently also. One hero will be using one tube, one broken cord to tap here and put a tube inside. That is the emergency tracheostomy. That is known as emergency needle. Emergency needle tracheostomy known as cricothyroidotomy. Thyroidotomy. Emergency needle cricothyroidotomy. Okay, it is how to identify the thyroid notch, certain prominent notch level, and go below and identify the cricothyroid membrane. It's a avascular membrane. Put a white bore needle like 16 gauge. Needle is inserted. Or you can insert even 3 mm or 4 mm catheters can be inserted. 3 mm, 4 mm catheters can be inserted at that membrane. And through that you give high flow oxygen. High flow oxygen is given. This is known as emergency needle cricothyroidotomy. But this procedure is contraindicated for whom? It should not be done for children because they develop subglottic stenosis. So it should not be done for children less than 12 years. It can go for stenosis. Subglottic stenosis can happen. Therefore, it should not be given for children. And this type of high flow oxygen should be given only for half an hour, maximum for half an hour. Otherwise, what will happen? The oxygen will be going on. There is no way for the CO2 to come. Therefore, the CO2 will accumulate and it will cause CO2 retention. Therefore, please remember, high flow oxygen is given only for half an hour and CO2 retention may happen. Please don't forget this. So you all know well, elective tracheostomy we will be doing in the second and third tracheal rings. In the second and third tracheal rings, we will be doing an elective tracheostomy. We will be discussing about tracheostomy in another chapter. So please don't forget, these are the points you should not forget in intubation. And there is a mnemonic not given by Bailey but given by ATLS himself. ATLS training is a special training in foreign countries. Many people go for ATLS training, advanced trauma life support guidelines. That training gives a mnemonic known as lemon. L for airway. This is lemon for airway. Look externally. So in an intubation, what are the things you should see? Open the mouth and see any foreign body inside. Sometimes the below everything on paroda. The paroda will be obstructing the trachea. That is the cause of airways. Then you remove it. Some foreign nature may be obstructing the airway. So look externally. That is L for look externally. And E for evaluate 3-3-2 rule. Not so important for PG, but technically what is 3-3-2 rule? Evaluation of 3-3-3-3-2 rule. Take 3 fingers. Ask the patient to open the mouth and put the 3 fingers in the mouth. If 3 fingers are entering the mouth, this mouth is good. And keep 3 fingers from the notch to base of the tongue or the base. You should have 3 fingers. Okay, between the notch to thyroid notch to floor of the mouth is 2 fingers. Like this, thyroid notch to floor of the mouth is 2 fingers. Another 3 fingers between the distance between thyroid 1 and the chin. So please don't forget, this is not essential for PG, but essential for super specialty entrance. 3 fingers enter the mouth. 3 fingers in between incisors. We are putting 3 fingers between incisors. 3 finger distance from hyoid bone to chin. Hyoid bone to chin, 3 fingers, and 2 finger distance from thyroid notch to base, okay, to the base of the floor of the mouth, base of floor of the mouth. So this is 332 rule, 332 rule, E for evaluate for 332 rule, and M stands for Mallampati classification. Mallampati classification. You will be reading anesthesia. In this classification, what structure you will be examining for? You will be examining for the soft palate and the uvula. Okay, you will be examining the soft palate and the uvula in this Mallampati classification. You will be examining this in class 4. Only hard palate will be seen in this. This is class 1 to 4. 1, 2, 3, 4. In Mallampati classification, class 4. Once you open the mouth, only hard palate is visible. That is known as Mallampati class 4. But you will be reading this classification in anesthesia. This is not my job to explain Mallampati. But remember, Mallampati classification has 4 classes: class 1, class 2, class 3, class 4. Class 4. Once you open the mouth, only hard palate is visible. In class 1, soft palate, uvula, everything is visible. That means it's a wide open cavity inside the mouth. So this is easy to intubate. Class 1 is easy to intubate because soft palate uvula. In class 4 is difficult to intubate because I'm opening the mouth, you're seeing only the hard palate. Okay, and O for look for any obstruction. Look for any obstruction. Look for any obstruction. Sometimes there will be some obstruction, so that should be looked out. If you have a laryngoscope, you should put a laryngoscope and minimum look for any obstruction. And last, look for neck tenderness. Don't go very tough in the neck because sometimes the patient may have spine fracture. If you check like that, patient will go for paraplegia. Look for neck mobility. So neck mobility. Look externally. Evaluate 332 rule, Mallampati classification, obstruction, and neck mobility are the points you should not forget in airway. I hope this is the points to be noted in A for airway. Okay, A for airway, please don't forget the landmarks, chin lift, jaw thrust. Okay, now coming to B for breathing. So when you see a patient, when he could speak freely, it means he could he could breathe freely. So you're asking his name, my name is Hamza, it means he's having a free air going and coming back. If he's having tachypnea, dyspnea, like that, what do you think? You should always look in breathing and look for tension pneumothorax. One of the dangerous things you should look here is tension pneumothorax may be there. Look for flail chest, there may be a flail chest seen in the patient, so flail chest may be there. There may be some pericardial tamponade. All these things will cause some issues that you can note in breathing. In fact, pericardial tamponade will not come here, will come under circulation. Tension pneumothorax and flail chest can be noted here. And if tension pneumothorax is there, you have to manage accordingly. Immediately you should put a needle for a percentage we will be discussing later. So this is B for breathing. Then C for circulation. Circulation is very important thing now coming after airway breathing. So circulation is measured by BP, measuring the BP. When you touch his hand, his peripheries are cold and clammy, means he has so much of loss of blood, hemorrhage, shock is having. So circulation is measured by BP. Okay, by doing a measurement of BP. And as soon as you feel the BP is low, look for bleeding spots. Bleeding sites should be looked out. So the bleeding can be seen one on floor, and 4 more. This is a mnemonic from Bayano. 1 on the floor and 4 more. So how much amount of blood is there on the floor? There is a 500 ml of blood on the floor. Some 2 pads over it. Each pad is around 400 to 500 ml. Blood is there in each pad and it is fully soaked. And if you have a clot of this clench size clot, it is 350 ml. So clot of this finger close, this size clot is 350 ml. One pad soaked fully will go for around 500 ml of blood is lost. And you have to examine for 4 more. 4 more are the cavities. Abdominal cavity you should look for blood. And you should look for chest cavity. And you should look for pelvic fracture. And you should look for long bone fracture. You also realize there's a pelvic fracture, there will be 2 liters blood will be lost. In a long bone like femur, 1.5 liters will be lost. And just you can even have 2 liters blood because of some hemothorax. In abdomen you have hemoperitoneum, there will be some blood. So these are the 4 more. So in a bleeding, what are the sites you look? You should look for floor, chest, abdomen, pelvis, and long bone. So these are the places where you should look for bleeding spots. And the moment you see such bleeding spots and the patient BP is low, immediately you should start your resuscitation, which we have already discussed in shock chapter. Let me give you a fast review now here. So what type of cannula you should put in these patients? What type of cannulas you should put for these patients? You should put 2 short and wide bore cannulas. You should put 2 short and wide bore cannulas. So what is ATLS recommending? What cannula ATLS manual is recommending is ATLS manual is recommending at least 3 Milflam. ATLS manual recommends 2 green Milflam on either side of the cubital. On this vein you should put 2 Milflams. If by chance this vein is not available, we are unable to put the vein, what will you do? We have to go for the next level. That is, you have to either go for cut down of the saphenous vein in the leg, or we have to immediately go for a central vein facilities are available. Go for internal jugular vein. So if you are there is no central vein facilities available, you have to go for a cut down. Immediately make a small cut down on the saphenous vein, put a cannula into the identified vein, or else you should identify internal jugular vein and put inside. That is one advantage for a very small child, children less than 6 years, and you are not able to get a line. You can put directly into the tibial tuberosity. You can put a needle inside and you can put intraosseous transfusion. Intraosseous you can do fluid fusion. Intraosseous into the bone. So children we do this intraosseous. So what are the cannula we use? 2 short wide bore cannula, green cannula, cut down or IJV supplied. So how much amount of fluid you infuse and what fluid we infuse? All those things we discussed in shock chapter. We infuse 1 liter of 7.5% hypertonic saline is the ideal fluid for these patients. 7.5% hypertonic saline, 1 liter should be infused, and we must maintain a permissible hypotension. Permissible hypotension should be maintained. What is this permissible hypotension? Please remember, the BP should not go very high or normal. At the same time, it should not go very low or some other patients should not go for low perfusion. For example, if it is very high, what will happen? There will be rebleeding from the already stopped bleeding spots. If you go down, what will happen? You will have decreased brain perfusion and patient may develop cerebral hypoxia. So brain hypoxia can develop. Therefore, we should have a BP at a permissible level of around 70 to 90. Systolic should be maintained. Systolic BP should be maintained at around 90. Okay, it should be maintained around 90. Systolic BP should be maintained around 90 millimeters. That will prevent rebleeding and will also prevent brain hypoxia. So this is the point you should not forget in circulation. And in circulation, there is one more point, that is crash 2 trial from ATLS manual. Crash 2 trial. What does a crash 2 trial say? Crash 2 trial says in the spot of trauma itself, if the BP is less than 90, systolic BP less than 90, and pulse rate more than 110 per minute, in the spot itself, where there is a spot of bleeding, in that spot itself, you can go and you can give 1 gram of tranexamic acid stat, immediately 1 gram dose. Okay, immediately 1 gram dose, stat IV in the spot itself, the spot of trauma itself, you should give 1 gram stat, and then you must give 1 gram 8 hours continuous infusion. So So 8 hours continuously you must infuse and 1 gram should be given stat. This is known as crash 2 trial. This is known as crash 2 trial, and the injection given is injection tranexamic acid. Please don't forget injection. So very important point is injection tranexamic acid should be given immediately for the trauma patients. Okay, this point is not forget. So now we go to the secondary survey that completes the primary survey. Completed airway, breathing, circulation, disability, and exposure. I have finished. E for exposure. After finishing everything, we should expose the patient and examine everything. Okay, that is known as ABCDE. And the primary survey, though I am discussing this topic for half an hour, this will be done in few minutes. All these things should be done in few minutes. Airway, breathing, circulation, disability, exposure, everything should be done in few minutes. Okay. And after completing this primary survey, now I will go to the secondary survey. Secondary survey is a detailed examination of the patient. Detailed examination of the patient is known as secondary survey. So I still remember in the PG preparation days of myself, we used to do secondary survey. What are the things you do? They ask. We will tell. We will do X-ray chest, X-ray pelvis, X-ray lung. That point is no more available now. Now the point is secondary survey. There is a simple one investigation available known as WBCT. What is it? In a secondary survey of a trauma patient, we advise them to go for a WBCT. What is WBCT? Whole body CT scan. Whole body CT scan is equal to 72 X-ray chest. So this much amount of radiation exposure, is it justifiable? Will it cause cancer? Yes, it is still justifiable, though there is a small risk of cancer. It is still justifiable. For severe road traffic accident injuries, we must do whole body CT scan is a must. For severe injuries, we must do whole body CT scan, which is actually equal to 72 X-ray chest. The report is obtained in the moment you do whole body CT scan, the report is obtained in minutes, and you can get a detailed report of entire body. Detailed report is obtained in 45 minutes. So we have to do, because sometimes you will be concentrating on abdomen, there will be an injury on the thorax, you will be concentrating on a pelvic fracture, there will be injury in the brain. So whole body CT scan is for severe injuries. You will get a detailed report in 45 minutes in whole body CT scan. And in secondary survey, do you do any examination? Yes, we do an examination that is known as log roll examination. An interesting point is this procedure is no more advised now, because unwantedly by waiting for log roll and other things, the time delay is happening for whole body CT scan. So now ATLS man advises no need of log roll examination. So what is log roll examination? Log roll examination is done by 4 people. It's done by 4 people simultaneously. They should all rotate this patient on one side. One fellow will stand near bed, another fellow near chest, another fellow near lower limb, and 3 people will rotate down, and the 4th one will come and examine the spine. This log roll is primarily meant for spine examination. Please don't forget this point. So log roll is primarily meant for spine examination, and we can also do accessory along with spine examination. We can do rectal examination and look for anal sphincter tone. Or if patient is unconscious, we can test for wink reflex in the anus, whether the sphincter is contracting on stimulating the anus. Wink reflex we can do, and also we can see for the old sign which is not done now, known as Vermeulen sign, that is known as floating prostate sign in a membranous cervical injury. Floating prostate sign in a membranous cervical injury. All these can be done in log roll. So what are the things which are done in log roll is spine examination can be done, rectal examination, sphincter tone can be done, wink reflex can be done for unconscious patient, and Vermeulen sign is done for floating prostate in case of membranous cervical injury. All these things are not needed now. All these things are not needed now, because when you have whole body CT which can show everything, So this tests are all not done now. So if there is a question, what is the contraindication for log roll? This question can come for exam. What are the contraindications of log roll? Is pelvic fracture. Pelvic fracture is a contraindication of log roll. Please don't forget this. Why? Because if there is a pelvic fracture and hematoma, if you try to do log roll, immediately the clot inside will get disturbed and they will rebleed and the clot will get disturbed. So contraindication of log roll examination is pelvic fracture. Please don't forget this point also. And in secondary survey, you will be asking certain history known as ample history. Ample. The histories we ask these guys are ample. Allergy history. Secondary survey is ample. Allergy history. Any medicine history. And pregnancy history, whether the patient is pregnant or not, pregnancy history, and L for last meal, and explain the mechanism which happened, explain mechanism of trauma. This is known as ample. Allergy history, medicine history, and pregnancy history, or any present illness. The patient may be having diabetes, hypertension, all those things now we will ask. And when the patient had a last meal, because if we need that for surgery, we can plan according to the last meal and explain mechanism. Some fellows will ask what happened, sir, I'm driving a bike like this, suddenly they explain everything. And when they explain the mechanism, you can suspect what are other injuries that will be hiding for the patient. Sometimes you will be examining an abdominal injury, and by the way the patient is sitting, you will tell, I fell down like this, you can see a fracture here. You can examine. That is explain the mechanism. By explaining the mechanism, you can find out some other injuries also. So these are the things which come in secondary survey. Please don't forget secondary survey. So secondary survey is nowadays don't do anything, we directly go for a whole body CT scan, and a whole body CT scan is equal to how many X-rays? Please remember, sorry, I told 72. Please change it as 76. One whole body CT scan is equal to 76 X-ray. Expected MCQ direct and from beginning. It is indicated for severely injured patients. So in secondary survey only we also take X-ray cervical spine. When you suspect cervical spine injury, for example, patient having spine tenderness, when will you take spine X-ray cervical spine? When patient is having cervical spine tenderness, or there is neurological disease, etc., we will be taking routinely in those days AP view and lateral view. 2 views we are taking in those days. Now for this they have kept a criteria known as nexus criteria. Nexus criteria and C spine rule are the 2 rules I will be discussing later. In those days we are doing for all people. Routinely we take X-ray cervical spine. Now X-ray cervical spine is done according to nexus criteria and C spine rule, or Canadian C spine rule. That is also known as Canadian rule. These are many rules from ATLS manual. In this nexus criteria is very important. So nexus criteria I will be explaining it in detail when I am discussing the comparison of ATLS and ATLS. I will explain what is nexus criteria. But remember the name nexus criteria is done for X-ray cervical spine. Please don't forget this point. So now Mr. Ram, who is admitted in hospital, you have done primary survey, secondary survey, everything completed for him. Now is the time for making some scoring systems for trauma. Scoring systems in trauma. You all know there are so many scoring systems, and the scoring systems include injury severity scoring, RTS score, TRIS score, MES score. What is MES score means? Mangled. This is the only score is asked in exam. Mangled extremity severity score. Mangled extremity severity score is known as MES. So ISS, RTS, TRIS, and mangled extremity severity score are the various scoring systems we commonly use in trauma. In this RTS, what are things will come in RTS? This question is asked in 5 years back at GATE exam. I made this mnemonic. This RTS does not stand for this. R for respiratory rate. T for I made the mnemonic for understanding purpose. INC-BP. So T for INC-BP and S for Glasgow Coma scale. So this is RTS score. So RTS score means respiratory rate, INC-BP and Glasgow Coma scale. And similarly for TRIS, R for RTS score, I for injury severity score, S for seen age of the patient, and S for specific mechanism of injury. So what are the factors which come in RTS are respiratory rate, TINC BP, and Glasgow Coma scale. Respiratory rate, TINC BP, GCS. This is the only question asked. What are the factors in the score? So please remember R for respiratory rate, T for TINC BP, S for Glasgow Coma scale, GCS. And this it includes this RTS, ISS, seen age, and specific mechanism. And this Mantle Extremity Scoring System is the only score which they can ask you in present day exam. This is the scoring system mainly for limb injuries, for upper limb or lower limb injuries. I made the mnemonic again. It is not there. MES means does not, it stands for Mantle Extremity Severity Score. M stands for mnemonic, main energy that caused this problem, main energy that caused this mechanism injury. E for extremity, which extremity is in ischemia. Extremity, ischemia. And S for seen age, and another S for shock. So this is MES. Main energy that caused this extremity ischemia, seen age, and shock are the things to be noted for MES. Main energy that caused this extremity ischemia, seen age, and shock are the things for Mantle Extremity Severity Score. So ISS, RTS, TRIS, MES. Please note these points in your workbook. Okay, RTS, TRIS, and MES. But what is the only question asked recently is AIS scale. Please don't forget what is AIS scale. AIS is abbreviated injury scale. 1, 2, 3, 4, 5, 6.7. This is how they mention this score. 1, 2, 3, 4, 5, 6.7. This is, they will make it as an application. They will make it as an application and give this score. In this, AIS 1 stands for the region of injury. Which region is injured will stand for 1. AIS 1 stands for anatomical body region. And 2 stands for type of anatomical structure. Type of anatomical structure. Usually, this all is not important. 2 stands for type of anatomical structure. 3 stands for specific anatomical structure. 3 and 4 will stand for specific anatomical structure. And 5 and 6 for level of injury. And 7 post dot score 7 stands for grade of injury. So please don't forget AIS scale is given as a value 1, 2, 3, 4, 5, 6.7. In this, 1 is the only question they have asked in exam. The region of injury is what is asked in exam. AIS 1. AIS 1 has 9 regions in your body we are going to discuss. In this trauma chapter, I am going to discuss these 9 regions. That is the purpose of this introductory chapter discussion. 1 stands for head injury is 1. 2 stands for face injury. In AIS 1 stands, 2 stands, 3 stands for neck injury. 4 stands for thoracic injury. 5 stands for abdominal injury. 6 stands for upper limb. 7 stands for lower limb. 6 stands for, when you hit 6, your spine will be painful, remember like that. 6 is spine, 7 is upper limb, 8 is lower limb, 9 is burns. So this is AIS scoring system. AIS scoring system 1, 2, 3, 4, 5, 6, 7, 8, 9. So this is AIS 9 regions. Please don't forget. The question asked 2 years back in AIMS is AIS 1 stands for head injury, 2 stands for face, 3 stands for neck, 4 stands for thorax, 5 abdomen, 6 spine, 7 upper limb, 8 lower limb, 9 burns. So the scoring systems you must remember for your exam in this are MES scoring system. You should remember Mantle Extremity Severity Scoring. You must remember it is a scoring which decides whether to do amputation or preserve the limb. A limb is getting ischemia. Whether to amputate or preserve the limb is based on this score. Another score, only score asked in exam, explain the score is RTS, respiratory rate, TINC BP, GCS. And the one score which is expected even for this year is abbreviated injury scale, which is 1, 2, 3, 4, 5, 6.7. This is 1, 2, 3, 4, 5, 6.7. Okay, so this is the scoring system. Okay, in a trauma patient, in the introduction itself, I want to tell you one more point, that is damage control surgery, which I have already discussed with you in a short chapter, but let me discuss damage control surgery, the other points. So damage control surgery is indicated for indication of damage control surgery are number 1, hypothermia. Number 2, acidosis. Number 3, coagulopathy. What are these 3 actually known as? Hypothermia, acidosis, coagulopathy. These 3 are known as what? They are known as deadly triad of trauma. Hypothermia, acidosis, coagulopathy. So what are the indications of damage control surgery? Number 1, hypothermia. Number 2, acidosis. Number 3, coagulopathy. Number 4, the serum lactate level is also taken into account. So tell me what is the serum lactate level for doing damage control surgery? And the level is less than 2, we must do damage control surgery. Sorry, the level is more than 5. So less than 2 is good resuscitation. When it is more than 5 millimoles per liter, patient is not having good resuscitation. And injury severity score, the score we make is more than 36. And BP is less than 70 millimeters mercury. So what are the places where we make damage control surgery? Means hypothermia, acidosis, coagulopathy. Don't forget this 3. Serum lactate more than 5 millimoles per liter. Injury severity score more than 36. BP is systolic BP is approaching less than 70. And transfusion has happened. Blood transfusion is going on, and we have transfused more than 15 units blood. 15 units blood is transfused. These are 7 points from radian law. Expected question for AIMS. So when will you do damage control surgery in a trauma patient? So trauma patient, I will do damage control surgery for hypothermia, acidosis, coagulopathy, serum lactate more than 5, injury severity score 36, SBP less than 70, and transfusion needed more than 15 units of blood. Okay, 15 units of blood. So another method of management is yearly trauma care. What is this? Yearly trauma care. It is known as ETC. It is a definitive management which is done for the trauma patients. Instead of doing damage control, you can do one time, everything we can do in one time. So yearly definitive care is done, or yearly trauma care is done within 36 hours. Within 36 hours, we do yearly trauma care. If there is no hypothermia, no acidosis, no coagulopathy, serum lactate less than 2, and patient is hemodynamically stable, we can go for yearly trauma care. Done in 36 hours. So in the management of trauma, there are 2 treatments. Please remember. One is damage control surgery. Patient is very sick. We have to do mild treatment and now for that is damage control. Another is yearly trauma care, also known as definitive care, which can be done. The patient is hemodynamically stable. So please remember, this is from Alien. This topic is expected topic from Alien now. So how we are deciding as trauma surgeons? How we are deciding? We decide based on simple test: serum lactate level. We measure serum lactate. If it is less than 2 millimoles per liter, what we do? If it is more than 5 millimoles per liter, what we do? Very simple. If it is less than 2 millimoles per liter, means you have done an excellent resuscitation. You can go for yearly trauma care, ETC. If it is more than 5 millimoles, you have done a poor control. Therefore, you have to go for damage control surgery. And 2 to 5 is equivocal. They will be on resuscitation. 2 to 5 millimoles is equivocal patients. They will be on resuscitation. So less than 2, yearly trauma care. More than 5, damage control surgery will be done. And in damage control surgery, Sabiston says 3 headings. In damage control resuscitation, what are the 3 steps in damage control resuscitation from Sabiston? This is what I discussed in shock chapter. That is in damage control resuscitation from Sabiston, there are 3 phases: phase 1, phase 2, phase 3. Can you tell me what is phase 1 which I already discussed? Phase 1 is in emergency OT. In emergency OT, phase 1 happens. We do only a minimal surgery. For example, if there is a liver laceration, I won't go and repair the laceration. I will pack the liver. If there is a bowel tear, I won't go and repair. I will keep the bowel outside. So I will keep the bowel outside as a stoma. Like that, I will go fast inside and I will come out inside from the theatre fast. And I will do a fast operation so that the patient should not die on surgical stress. And in fact, I will not even close the abdomen, I will close with upside dressing or vacuum assisted dressing. I will do an upside dressing or a vacuum assisted closure device I will do for such type of patients in phase 1. Phase 2, if it is done in SICU, surgical intensive care ward, we do phase 2, that is hypothermia, acidosis, and coagulopathy is managed in ICU. So this is a deadly triad which will be managed in ICU. And phase 3 is a definitive surgery will be done in elective theatre. Definitive surgery. Patient will be shifted. This is 0 to 48 hours is phase 2, and after 48 hours patient will be shifted to definitive surgery. Now you have all team, your team will be there. Reverse will be there, passive will be there, everyone will be there. You will now do your definitive surgery and close the abdomen. This is from Bailey now. This I have explained in detail in shock chapter if you go back. Okay. But what Bailey says there are totally 5 stages. Bailey says the same concept only, nothing new. Bailey says there are 5 stages. Stage 1, why am I because many times national questions are from Bailey. Don't get confused between phase and stage. Bailey says as stage. So in Bailey, 2, 3, 4 is nothing but about 3. So first one is selection of patient. Okay. Selection of patient is stage 1. Selection of patient is stage 1. And stage 5 they have given a name, close the abdomen. So in an abdominal injury, damage control, what are the stages according to Bailey and Love? This is from Bailey and Love, 27 division. This is from Sabiston, phase 1, phase 2, phase 3. So Bailey and Love says very simple point. He says 5. Stage 1 is select the patient. Stage 3, 5 is close the abdomen. 2 is nothing but same like phase 1, emergency OT management. In emergency OT, we will do only stop the bleeding and stop contamination. We will stop the bleeding, stop the contamination. That is stop bleeding and stop further contamination. That is stage 2. Stage 3 is, what is stage 3? Stage 3 is ICU management. Stage 4 is elective OT, definitive repair. So this is stage 1, 2, 3, 4, 5 from Bailey. Stage 1 is selection of patient. Stage 2 is we have to shift them to emergency OT and do the treatment. Stage 3 is ICU management. Stage 4 is elective OT management. Okay. Stage 5 is close the abdomen. Let me show you the images around now. What you have discussed. So please don't forget the triage. There are 4 colors: red, yellow, green, black. I didn't tell about black because I wanted to tell black patch. Black patch people are very we have to pity for them because they are not dead alone. Not only dead people. Those who are about to die, we know he's alive, but he will die definitely. They will be given black patch because cardiac arteries factor. Brain is crushed and brain is out. Still the heart is beating. Such things are coming under black patch. Whom we cannot say even if you should be in the hospital will come under black patch. So red, yellow, green, black. So black is not only dead patient, people who are about to die and moribund patient. Okay, and this is how you manage a trauma patient. The moment you see the patient, you should do primary survey, airway, breathing, circulation, disability, and exposure. So airway, please see the images are all the points I have told you. So airway manuals, what are the manuals we done? This is known as jaw thrust manual. Please see the image. This is from ATLS manual. This is chin lift manual, ATLS 10th edition, chin lift manual. And this is dual airway. All the images are taken from ATLS edition. This is dual airway. You can see the dual airway. And this is the hard cervical collar. And this is a hard board on which you shoot the patient in trauma. Okay. So I told you when you intubate, intubation is orotracheal and nasotracheal. Nasotracheal intubation is contraindicated for base of skull fracture, maxillofacial injuries, and patient having CS of rhinorrhea. Okay. So these points are all I discussed. So L for look externally, E for evaluate 3-3-2 rule, and M for Malapathy classification. In Malapathy 1 you can see the soft palate and uvula. In 4 you will see only the hard palate. You will see only the hard palate. You will see only the hard palate. Here you see soft palate and uvula. Okay. O for requiring obstruction, N for neck mobility. 11 assessment is for airway. Then we saw for breathing, we saw for circulation, and we took for breathing sites, and we may how to maintain the circulation. We discussed by putting a 2 green and you should maintain circulation. 1 liter of hypotonic saline is infused. And maintain permissible hypotension. Please maintain permissible hypotension. And we discussed about the crash tube trial in which 1 gram of tranexamic acid is given IV in the spot itself, and another 1 gram is given 8 hours for people who are having BP less than 90 and pulse rate more than 110. So secondary survey, you can see this is a video showing you the secondary survey of lab roll examination. See, now 3 people are rotating the patient, and the 4th one is going to come there and going to examine. The purpose of this examination is we are very safe that the spine is not disturbed. This is known as lab roll examination. Please don't forget this point. So what is the contraindication of lab roll? Pelvic fracture is the contraindication of lab roll. Please don't forget this. It's contraindicated in pelvic roll, and in fact, lab roll is contraindicated in primary survey now as there is unwanted time delay in whole body CT scan. It is unwanted taking delay. So nowadays people are not doing lab roll examination. They're shifting for WBC. Okay, whole body CT is done now. Sample is told you whole body CT is equal to 76 X-ray chest, and whole body CT still has a risk of 2% cancer in future. It is having a risk of 2% cancer in future. And scoring system we discussed RTS score, MES score, or 2 scores which can be asked in exam. R for respiratory rate, T for INCBP, S for scale, M for main energy that caused the injury, E for extremity ischemia, S for scene age, and other S for shock. The another score is this score, abbreviated injury scale score. Please don't forget abbreviated injury scale 1 to 9, or the score given for first digit. The first digit is given 9 points. 1, 2, 3, 4, 9 points. And management trauma, please don't forget damage control and early trauma care which I discussed. Okay. So there are 3 phases according to Sabiston. Phase 1 is elective OT. Phase 3 is definitive treatment in. Phase 1 is emergency OT. Phase 3 is elective OT. Phase 2 is ICU management. Phase 1, Phase 2, Phase 3. Please don't forget these 3 phases. And when you come to period now, there are 5 stages. Stage 1, select the patient. Stage 2, emergency OT, control hemorrhage and contamination. Stage 3, ICU resuscitation. Stage 4, definitive repairs. Stage 5, closure of abdomen. This is the 5 stages according to period. Okay. So that completes the introduction of trauma chapter. Okay, introduction of trauma chapter is very completed now.